Faith Forward Media, this is Healthcare Musings. I'm Dr. Hashem Hasabala. Welcome everybody to Healthcare Musings. So happy to have you with me. I am delighted and honored to have Dr. Eugene on the show today. This is a day in the life of a teleintensivist. I think there is a lot of misunderstanding of what a telecritical care physician does. There's a perception that there's some doctor in the box somewhere that's just sipping coffee and enjoying life and, not doing anything, not contributing to the care. The literature on telecritical care has been all over the place. There's a recent study that has been published about the VA that showed prolonged telecritical care deployment, as they called it, improved outcomes, but that's at the VA. Dr. Ye can tell you about the research that he's doing with sound critical care. So I just wanted to have him on the show to kind of describe what it really is like to be a telecritical care specialist. So welcome, Dr. Eugene Ye. So happy to have you.
Thank you so much, Dr. Hasabala. I appreciate it. It's really an honor and privilege to be here. Fan of your work, really. All your podcasts and all the literature that you put out. So I appreciate you having me on your podcast. It's looking forward to this. I joined Sound about 2.5 years ago. To my story, kind of to give you a little background, I graduated Cedars-Sinai, and after that joined a private group, and shortly after moved to Optum, and had a great time there working pulmonary critical care. Great, staff and my colleagues. The opportunity to come to Tele-ICU kind of fell in my lap, to be honest. One of my colleagues had joined the group, and it was a good time for me, having a third boy, which is a lot. And it made sense for me from a family standpoint and work business life. So when I joined, I was a little skeptical because I heard about Tele-ICU 7 years ago when I was kind of interviewing, and they're the bunker model, the one you kind of classic know about, multiple screens, multiple hospitals, a doc in a box, if you will, like you said. So when I came to Tele-ICU here at Sound, the model is completely different. The model is as if you were on the ground, rounding in the ICU, just like what I was doing at Optum. So it was a pleasant surprise and a real life-changing and work experience changing achievement, to be honest. And so definitely proud to be part of this group and can't wait to tell you more about it.
Absolutely. So, and you, just for the audience, Dr. Ye is consistently been cited as one of our best, which is why I wanted to have him on the show. I mean, I really want him to share his secret sauce about what makes him, because he's just universally praised by everywhere we practice. So I want to kind of hinge on that. You said that you were skeptical when you first started. So because I used to work in a bunker telecritical care model, and it was like you said, multiple screens. We're covering literally 50, 100, 150 beds per physician. And there's very little that you could do, and to make a meaningful impact. And we were being paid well, right? And I just didn't know what the value proposition was for the hospital system other than leapfrog compliance. What changed your mind about the model at Sound Critical Care, or what is it about Sound that differentiates it from other telecritical care practices?
No, great question. And I got to give kudos to, first, my parents, to be honest. I think, raising kids, the parenting and trying to teach them anything, I got to give my parents a lot of credit for, teaching me some, the morals and values and how to treat people and how to have respect to, your work and also your patients. Second to Cedars-Sinai, I really had a good time there, and I think I learned a lot in terms of clinical practice and how to, act professionally. And our leadership here at Sound is amazing. I mean, Dr. Steve Matchett, Dr. Serge Zanotti, and Dr. Jake Adams. I mean, we have an amazing team that leads the forefront of how they vision Sound physicians and Tele-ICU to be. Really something that really creates this environment that is good. Camera issues. Let me try to adjust that here. Sorry. Okay, there you go. Sorry. Creates this environment that allows better workplace, collaboration, and it's the perfect setting for the model that Sound Physician has to kind of go into that. We round as if we're rounding here, live at an inpatient ICU. So you get on the camera from home. So obviously that's the biggest change there. But you're doing everything as if you were there. So you're rounding with the nurses. You're chart reviewing real time. You're talking to the patients. You're talking to the family. You're collaborating with the entire support team. Physical therapist, pharmacy. Multidisciplinary rounds, as if you were there. And it doesn't feel like you're in a camera a lot of the times, because you're just talking as if you were talking bedside. The difference, obviously, the exam, which the residents or fellows or nurses help you with. Besides that, it just feels like you're there. So to kind of answer your question, how does our sound physician? I think it creates that environment as if you were really there, and it feels as if you're part of that practice, as if you were just on site. And the advantages of having tele-ICU is obviously the efficiency that we have. I mean, with Epic Live in our computer, a dual screen, so you have another screen looking at images, reviewing any literature you like to do, literature search you'd like to do, and you're talking to the patient, and then you're putting orders in real time. Different than the bunker mod that you talked about, right? Where you're just, triaging and like you said, like what's the kind of the end goal here? We're just trying to put out fires, right? But here, the end goal is to provide the most professional clinical, experience and medicine you can for the ICU patient. So putting in orders, chart reviewing after rounds, kind of going back, bedside, saying, hey, did my interventions work? What do we need to change? What do we need to adjust? And that's the advantage, I think, that we have here at TeleICU than any other model, I think, that, previously to that.
Absolutely. That's great. And so do you feel there's a little bit of an awkwardness on the part of patients or their families when they see a doctor on a screen? Or, I mean, sometimes I kind of feel it's not the same, right? You can't reach out and touch their hand and say, I'm so sorry. And at the same time, you still can have goals of care conversations, and you can discuss about what they would want to do and code status and all those things. Do you feel that the screen is a barrier, or not really?
At first I thought that would be, but obviously the majority, 90% of my interactions, I don't have a question of like, oh, can I see a real physician, or where are you at, your computer on the screen. I would say, like I said, 90% they don't question it. They treat me as if the clinician that was bedside. It gets some getting used to, obviously, for patients and staff. But in our time of age, technology is so advanced with the pandemic that kind of grew this type of the business. I think it's kind of more commonplace, right? Everyone has AirPods, earpieces, and technology is just leading the forefront of this, and it's a natural progression, especially with AI now. So I think that people are just getting more used to it and understanding that deliver the same quality care, but just from a camera standpoint. The ability of a lot of our cameras is we have the ability to kind of even pan and move the camera and zoom in to sometimes a higher quality than you can, almost like an Iron Man kind of thing, where you can zoom in and have ability to see the telemonitor crystal clean, then zoom out and go talk to the family. So, I imagine in the future with technology being better, it's going to be even more advanced and potential for a hologram. The sky's the limit, to be honest. So the barriers are a little bit
holographic
less.
projection.
I think it'd be amazing.
Holographic projection into the room, which would be cool.
For sure.
I think robotic procedures, maybe, right? Maybe you can do that might necessitate being in a facility, And it's still, I mean, if you can do a robot in the OR, why can't you do a robot across the country, right?
Of course, and that's a good thing we want to bring up too. Is we have a team on site to do our procedures. Obviously, you can't do that now. Hopefully, in the future. But our APPs, our residence fellows, our hospitalists, emergency medicine, doing our intubations, our lines, any other procedures, in the ICU. But the technology growing, I think it's definitely within reason that potentially some of these procedures can be done remotely. It's already been done in a surgical suite. The Da Vinci system. So it's definitely possible.
Yeah, absolutely. So are you, the way you scale the practice is that you have one physician covering multiple hospitals, and the way the leadership team structures the shift is so that you're not overwhelmed with four super high acuity, super busy units where there's no way you could do that. You could even do that if you were on site at one hospital and you had four people crashing at the same time. You would not be able to do that. And there is a special skill. Tell me if I'm wrong, Dr. Ye. There is a special skill with having sometimes two or three critically ill patients being critically ill at the same time. Talk to me about that.
I think a lot of intensivists, kind of have this built in, right? They have this personality, they're able to do multiple things at once. At home, they're probably doing laundry, they're doing homework with the kids, or making dinner. And so, for us, it's almost like a natural ability in some regards. So this tele ICU, format, I think works well for our ability and our superpowers, if you will, traits. So, that we build, the hospitals mostly in kind of the rural, urban areas, some, in academic and also available, in the inner city. But targeting these hospitals where they need, some kind of ICU support where they're not able to. So we kind of set up, our shifts based upon, like you said, we're not going to pair multiple hospitals that are high acuity together. So we'll pair, hospitals that have different acuity, and 3 or 4 hospitals at most, maybe 2, 3, all together. With the coverage for that 12-hour shift, to be able to, really see the gambit, of all those type of patients. With our system setup, we're constantly reevaluating if one hospital needs more attention. Do we need to shift things around with our leadership that me and you are heavily involved in? It's an evolving process. I think that we've done a pretty good job in terms of how we try to scale and how we grow with that and make the changes appropriately. These hospitals that they don't see any ICU doctors. Maybe they'll get a locums here and there, but this scarce and to these ICPs, they don't have the opportunity. Multiple together, we're able to see more, and with our multitasking kind of abilities, if you will, it seems seamless. Now there are some challenges, obviously. You have to have that knack, right, to be able to triage, and that's where it gets, the nuances of the field itself, where you'll get a call from a nurse, dealing with some kind of unstable patient with ventilatory changes or pressure changes, and all of a sudden you'll get a call about a patient that's decompensating and potential code blue. So you're running code blues, and then 1 minute, and then telling a nurse, hey, you got to hold on, I got to triage, and they'll get back to you in a little bit, and potentially a third side calling. So it does get challenging, and you have to kind of be able to be quick on your feet, adjust things accordingly, put it into the management of what's most important right now. This tele ICU is almost like an art in that way, where we do this as part of our personalities. We were on site ICU, but here it kind of takes it to the next level, like in a video game. We're at the next level where in terms of how we manage multitasking and triaging.
Yeah, absolutely. I think that's a common misconception, is that it's just, you're just sitting and you make some recommendation. And that's how some models are, right? They just make recommendations and then they go away. We're not like that, right? You're managing. You are the manager of the critically ill patient that day or night shift, right? And so, and I think that's that's the challenge that people don't necessarily understand.
You know, you definitely hit the nail on that because there was an article that we reviewed together, the New England Journal, that you know criticized tele-ICU as not having any successful outcomes and no benefit. And you looked at the article in a little more detail, you realize that what they're providing is completely different than what we were doing. They were just providing some consultation services for a couple hours, maybe a little MDRs, and that's it. There was no real-time ordering. Their consultation recommendations had to be, kind of screened and either implemented or not implemented by the hospice, and that's completely different than what we're doing. We're actually managing the care. We're delivering, the orders, discussing the plan of care with the nursing staff, the leadership, as well as the patient, in real time. So that's what makes it, um, different completely. Now I'm excited about that, new article that just came out, by the VA, a pretty long-term study that shows, the clinical improvement in ICU length of stay as well as mortality. I think that hopefully this is a launch pad to show that tele-ICU is the way of the future in a lot of regards. Now, our article that we published at SCM.
Yeah, talk to me about the
yeah,
article
no, yeah.
that you submitted.
Oh no, submit with you. You're excellent writing, so I appreciate you. You're like a chat GPT in terms of writing. You're amazing, so I love your writing style.
You're too kind.
Oh no, it's great, and we collaborate on this pretty quickly. We're excited to submit it to SCM. Hopefully, get approved or But in that regard, we had a hospital, a rural hospital, that had 2-year data showing improvement in ICU length of stay, ICU readmission rate, and then ventilator days. So we had, really the main kind of crux of ICU outcomes with positive data throughout those in the last 2 years. So we're excited to publish that, submit it, hopefully publish it. And then moving forward, we have a lot of already, like you said, some good feedback and nurse satisfaction and other hospitals that we're trying to design and show that, what we're doing is so different than what was done in the past, and other models that are starting to develop, the VA. And I know my buddies at Kaiser also are, kind of doing, similar, format is going to change the way we deliver ICU throughout the country.
And you spoke about nursing satisfaction. So of course the patient is number one, and we also have the hospital C-suite. They're a client, and their satisfaction is important. And we also care about nursing satisfaction. Is that you're a medical director, so of several tele-ICU programs. So talk to me about how nursing satisfaction is also critical, pun intended, to the success of tele-ICU.
Yeah, I have the greatest, utmost respect for the nursing, ICUs, across every hospital in the country.
Absolutely.
They're the best. The best nurses are, in my guard, is the critical care nurses. They know, hands
100%.
down what to do, and we're very fortunate to have them in general. And our hospitals, we have all our nursing ICU. We're very proud of being a collaborative process with them, and it's important. It's important to deliver the care to the patient, obviously the utmost priority, but we want to deliver the care in a teamwork, collaborative way with the nursing team, because without them, we really wouldn't be here, right? So like they're really our boots on the ground, and teamwork environment where it's vital that we have the success of our relationship. So it is important. We review these nurse satisfaction scores and of all our sites and make sure that the nursing leadership is happy with what we're doing, and the communication is clear, and the feedback is received. Our sites, I was just working last night at one of our new sites, and where I'm program medical director, and talking to the charge nurse and just make sure, hey, what can we do? We implemented night rounds just a couple of days ago, and how's it going? What can we do to make changes? It's a collaborative process. So no, it's vital. It's vital to have the feedback that we constantly reevaluate. It's vital to have the nursing on the same page of what we're trying to do, and that goes to the C-suite too, obviously. hospitalists that everyone be on the same page. These meetings that we have for all our sites is vital to make sure that the consistency is there and it's continuing, year after year.
Absolutely, absolutely. That's so important. And so, kind of to wrap up, a day in the life of a teleintensivist is always ever dynamic, ever changing. It's not the duck in the box that does nothing. It is a challenging it's a challenging job, and one that's very satisfying at the same time. Would that be a fair assessment?
Absolutely. My 10 years now working since graduating from fellowship, to be honest, in the last 2.5 years, I've been extremely happy with my, career and job and colleagues, because we're delivering a type of care that really is an example for, really also all ICUs across the country. We're, focusing on the priority is, helping and being there for the patient, for the hospital, for the nurse, and constantly trying to evolve to improve how we deliver this professional, consistent, clinical care, and just trying to deliver the professionalism that is expected from really any physician. So I'm happy to be a part of this, and I think that tele-ICU is going to grow and expand, and the sky's the limit. It's exciting to see the technology, and with the AI, with jumping in and being more of a integration to how we practice medicine, it's really amazing to see how the human progress. So it's good, it's great, and I think that we're just going to keep on growing, and I'm really excited that some papers and literature are starting to show that amazing progress.
Yeah, and you can also bring care to where it wasn't before. Like we had the case in middle of rural California, where a young man had COVID, ARDS, and was gonna die. And his initial contact with all telecritical care, with all critical care, was remote, was telecritical care. And through our group and our connections, we were able to get him to an ECMO center, who was able to get him to a lung transplant center, and now he's alive, and he baptized his daughter, and they shared his picture. So you could deliver care everywhere with telecritical care that you just couldn't do before, and I think that's the power of telecritical care.
Yeah, and just just to kind of add to that, the thought is, and we're delivering care on the East Coast, our Central Coast, and our West Coast in different pods and throughout the United States. And these rural hospitals, just like you said, I had a patient, about 6 months ago, kind of similar, ARDS. We transferred to high-level care, received ECMO, and without us being there at that rural hospital, none of that probably would have happened, because the hospice, was, although amazing as it is, may not have the expertise in terms of, how to manage the critical care, patients in that way. So, just, a couple of days ago, we're taking care of a patient with eclampsia. I mean, we're seeing it all on these different, sites where they didn't have access to, ICU in general. So it feels rewarding. It feels rewarding that these patients that are on these kind of smaller markets or rural hospitals that they have these complicated cases at times where we're able to help them and provide the care that we described. It feels great.
That's fantastic. So more to come. I think the future is bright and exciting. Thanks so much, Dr. Eugene, for being on the show, and thanks for all you do for critical care.
Thank you so much, Hesham. I appreciate you. You've been a real role model for our company and to the critical care world. Really, just keep on doing what you're doing, your podcast, and it's been an honor and privilege to be here and just to talk briefly of day in life that what we do. And excited for the future and more to come. Can't wait.
Absolutely. Thanks, man. Thanks so much.
Thanks so much. Bye.
thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.